Hello everyone, I'm excited here today to present one of our latest works with the title of Autonomous System for Tumor Resection, Dual-Arm Robotic Midline Partial Glossectomy. The glossectomy here means the surgical resection of the tongue tumor. Tumor resection surgery is a primary treatment modality for many patients with early and locally advanced tumors, including head and neck squamous cell carcinoma and tongue squamous cell carcinoma. A patient might unluckily get diagnosed with tongue cancer, and surgeons will perform biopsy pathology and MRI scans to identify and localize the lesions. Then the surgeons will devise a plan to remove the tumor, along with its surrounding healthy tissues to make sure all the cancerous cells are removed from the patient to avoid any cancer recurrences or metastasis. And this layer of surrounding healthy tissues is known as the resection margin. And this is the look of the patient and the resected tumor right after the excision and before the wound is closed. Nowadays, the robot-assisted surgery is the standard of care for tumor resection. The teleoperated robotic systems have provided surgeons with superior vision, dexterity, accuracy, and ergonomics. However, two limitations still persist. First, the intraoperative tumor delineation is still difficult. Second, the surgical outcome relies heavily on individual surgeons' performance and experience. And as our solution, we developed an autonomous robot system or robot surgeon instead of a human surgeon to perform tumor tracking and resection. And we name it Autonomous System for Tumor Resection, or ASTR. And this is an incremental study that requires our prior efforts as shown in the references below. And now we have our autonomous dual-arm vision-guided robotic system that's been tailored for tumor resection. We have our primary electrosurgical tool to cut and separate tissues. We have a secondary vacuum grasping tool to manipulate and retract tissues. We have a near-infrared camera and RGBD camera to track and localize the surgical target, which has been placed in the sample holder. And in our work, the surgical target is the pork tongue. We chose it because of its anatomical resemblance to the human tongue and its easy accessibility. And inspired by the clinical setup, we immobilize the tongue base using a clamp, and we pull the tongue tip using the retraction suture. And we draw the tumor shape on the pork tongue surface, and we place the near-infrared markers along the drawn contour. So that makes our tumor model in this work a 3D tumor chip, as indicated by the drawn contour. So the resection task is to fully remove it from the tongue after applying the resection margin, both laterally and in depth. That further decomposes this task to two subtasks. First, the surface incision, to cut off the side edges of the tumor to the tongue. And second, the deep margin dissection, to fully remove the tumor from the tongue. Our autonomous control system is programmed in the real-time kernel of the Linux system based on the ROS and Oracle's frameworks. The two subtasks are first formalized into surgical process models and then programmed following the finite state machine techniques. This method bridges medical and programming knowledge, ensuring an accurate procedural representation and its robotic implementation. And here's a figure to show the key steps during the workflow. And it also illustrates that it takes a lot of image processing and robot planning algorithms to make this lengthy autonomous workflow feasible. And here's an 8x speed video to show the full procedure in action. In this work, we performed 6 consecutive autonomous resections using different tumor shapes. After each one of them, we took the top view, left view, right view images of the resected tumor for the result evaluation. The result proved that we achieved negative margins for all 6 experiments, with an average surface error of 0.7 mm and average depth error of below 2 mm. We also invited an experienced head and neck surgeon to perform the manual resections as a comparison group. The results show the precision performed by the autonomous resections can actually compete with the manual resections performed by the surgeon. Conclusions. As our first contribution, we developed the ASTR. It's the first autonomous robotic system that's been tailored for tumor resection. Second, we established an ontology-based research framework for complex autonomous robotic surgeries. This has been unfortunately omitted in this short video, along with our near-infrared fluorescent marking strategies to not deviate from the main focus on the robotic system and its surgical application. But if you feel interested, please read our paper for more details. As our third contribution, we reported the first study that accomplishes accurate autonomous tumor resection on animal tissues. Future work. We'll perform resections on more challenging scenarios, such as we are going to cut a bleeding sample. We will also employ a more complex control scheme to provide decision-making capabilities, such as reapply the vacuum if a vacuum failure. And here are the references we used in this presentation. I would like to thank all our Immerse Lab colleagues and our collaborators and the funding agencies who sponsored us. Without all of you, this work won't be feasible.